Thank you again for joining us for our webinar on LGBTQIA plus health and epilepsy in honor of Pride Month. I'm Allison Kukla, the Senior Manager for Programs and Partnerships here at the Foundation, and I'll be one of your moderators this afternoon. I want to run through a few reminders before we get started. The mission of the Epilepsy Foundation is to improve the lives of people affected by epilepsy through education, advocacy, research, and connection. The foundation is committed to serving each person with epilepsy as they come to us. We do not elevate or discriminate any group because all humans are worthy of care. We see everyone as a unique person and provide assistance and support to anyone who comes to us. Doing otherwise would put our mission and our community at risk. Our utmost goal is the care, dignity, and welfare of everyone living with epilepsy. We are so grateful to the speakers who have joined us and all of you who are with us this afternoon. As I said, we are so grateful to the speakers who are with us, and I am pleased to have with me Doctors Jenna Waldman, Suzette LaRoche, and Emily Johnson. We also have Derek Starr, who will be co-moderating with me. All of them bring different expertise to the conversation, and I'll first introduce you to them all, and then we'll start the webinar with a brief presentation, followed by discussion and Q&A. First, I'll start with Dr. Waldman. Dr. Jenna Waldman is a neurologist specializing in epilepsy at the University of Pennsylvania. She completed her neurology residency at New York Presbyterian Columbia University. Following her residency, she completed her fellowship at New York Presbyterian Columbia University in clinical neurophysiology and epilepsy, with a focus in evaluation of surgical management in epilepsy patients. Dr. Waldman's expertise is in epilepsy, with a focus on drug-resistant epilepsy, neuromodulation treatments, and reproductive and hormonal health in epilepsy patients. In addition to her clinical care of epilepsy patients, Dr. Waldman is active in resident and fellow education as a lead organizer for the educational lecture curriculum of epilepsy care at University of Pennsylvania. Welcome with us, Dr. Waldman. We also have Dr. Suzette LaRoche, who is a professor of neurology and the vice chair of community partnerships at the University of North Carolina and the past president of the American Clinical Neurophysiology Society. Dr. LaRoche was a founding member as well as past chair of the Critical Care EEG Monitoring Research Consortium and contributed to the creation of standardized critical care EEG terminology, clinical guidelines, and a multi-center database. More recently, Dr. LaRoche has been focusing her career efforts on improving healthcare delivery to patients with seizures and epilepsy in rural areas, which includes development of tele-EEG and tele-epilepsy resources. Welcome, Dr. LaRoche. We have Dr. Emily Johnson, who is an associate professor in the Department of Neurology at Johns Hopkins. She completed her neurology residency at Partners before completing epilepsy training at Johns Hopkins, where she's now faculty. She has clinical and research interest in sex and gender and epilepsy, as well as new onset unexplained seizures in older adults. Welcome, Dr. Johnson. And last but not least, my co-moderator is Derek Starr, who uses they, them pronouns. They were born in Brooklyn, New York, and is currently living in Washington, D.C., in the Washington, D.C. area. Derek's been a community activist for over 10 years, working on inclusion and equity within the LGBTQ plus community through drag artistry. Welcome, Derek. And welcome to all of you. As you can see, we have lots of expertise on this panel. So I'm so thrilled to have all of you here with me. So now let's start with a presentation from Dr. Waldman on LGBTQIA health and epilepsy.
Hi, thank you so much, Allison and the Epilepsy Foundation for organizing this second annual webinar during Pride Month. Allison already spoke about the mission of the Epilepsy Foundation, but I was also reviewing it and preparing for this, and it's about collaboration with the community and people with epilepsy to address all healthcare problems associated with those in epilepsy and promote access and education and change to foster improved care for seizures and epilepsy. And so, this webinar is really in line with that mission, with a focus on LGBTQIA and healthcare considerations, and specifically in epilepsy. You can go to the next slide. So this presentation is just going to kind of set the stage for our panel discussion so that we all have an understanding of the acronyms that we're using and some of the terminology that we're using to define the LGBTQIA plus acronym. What are healthcare considerations, and a little bit of an introduction on why it matters in epilepsy care. So you can go to the next slide. So hopefully many of you are aware of this acronym, although maybe you're kind of new to learning about it. And in general, we know that 1 in 10 people worldwide will identify as having a gender minority, and it's even becoming higher rates in younger generations, possibly due to a decrease in stigma over the years. It's important to define terms so that we kind of understand what we're referring to and talking to. And sex is thought to be what is defined at birth based on anatomical organs and innate hormones that your body produces, such as testes and ovaries, estrogen, testosterone, and other hormones that your body produces. Where gender is the self-defined gender expression and gender identity, and that might be static or fluid. And so cisgender is when the gender is aligned with the sex, versus trans is that in a difference of. And so that's where things like transgender terms come from, and then sexuality is kind of focusing on romantic orientation and sexual orientation. And again, this might be static or fluid. And so terms such as lesbian, gay, bisexual, intersex, asexual, and queer come from that. And obviously terms are important, but it's important to just be inclusive and kind of understand what's important to each individual. And so that plus term is to kind of include, additional terms that might be important to someone individually. All right, next slide. Unfortunately, we know there are healthcare disparities in this population. Social determinants of health are defined by healthcare access, quality, education, social and community environment, as well as economics. And we know in many diseases, in all diseases, when there are social determinants of health, those affect the outcome, prognosis, and control of many diseases. So it's not just about, what is the disease you have medically and what are the medication and surgical options, but all of these things matter when we should approach care and can determine how your care goes and how you can improve with your healthcare conditions. And so when we think about it in the LGBTQIA plus community, we know some systemic barriers includes higher rates of poverty, lower incomes, and employment discrimination. And that certainly can have impacts in healthcare access. Interpersonal discrimination, there are higher rates of slurs, microaggression, sexual harassment, violence, and these can impact physical health, psychological health, and certainly play a role in those social determinants of health. And unfortunately, sometimes that might come from within the healthcare community and healthcare providers. There's a lot going on politically right now in this area, and certainly there are some political opinions and current policies that really impact healthcare access. They impact education and awareness and really that environment, again, that can directly impact these disparities and discriminations that can happen, unfortunately, in the healthcare realm. And then biases impacting healthcare. There can be conscious biases and unconscious biases. And part of this webinar is hopefully to provide awareness and education so that providers can start to understand, the terms and what they mean, how they impact health, because that certainly is one of the components of kind of changing biases and how someone at an individual level can then approach care and then bring that to a practice and more systemic level to hopefully make larger changes. You can go to the next slide. And so again, this slide is, a little bit discouraging to look at, that when we look at kind of the LGBTQIA population compared to those that don't identify with those, they can feel in the healthcare setting that some of their concerns are dismissed. They get assumed about something that without even asking, believing that they're not telling the truth, that they're the cause of their problems and experiencing discrimination. And including your gender and sexual history can be a really important part of your medical care. And providers should be accurate and sensitive about obtaining that history. They should incorporate that and use your proper pronouns and discuss how it might be relevant to your healthcare and specifically your epilepsy care. So, this webinar serves as a space for education and awareness, and hopefully a dialogue that can improve education with the impact of trying to change this and to provide kind of a better community and better care for epilepsy patients. Next slide. And what about epilepsy? Epilepsy is one of the most common neurological diseases, and it affects all sexes and all genders. And there are some very specific things that we should think about when it comes to seizures in epilepsy. We have some knowledge that hormones can impact seizure and epilepsy control, both the ones that your body makes and in different hormonal states, like menstruation or periods. During different times, your body's in different hormonal states, and we know that sometimes that can have changes then in someone's seizure pattern. Pregnancy, which is a state of drastic hormonal changes, we know actually with good neurological care can be a time of stability and a time of continued control of your epilepsy. And menopause we know much less about, but again, can be a time of a lot of hormone changes and can impact then seizures. And so then that can be taken outside the context of the hormones someone's body is making. But if you're taking hormones externally, the question of is it safe and how they can affect your seizures and epilepsy. And then we know that gender affirming hormone treatment and anti-seizure medications, there are some that can interact with each other. And so talking about the risks and benefits and your goals, not only for your epilepsy care, but your gender affirming hormone care can be really important. And while we're not going to get into kind of anyone's specific treatment here on this webinar, you have to know there are safe options available that can be effective both with the medications you take and your epilepsy. But it's important to share that with your provider so it can be a discussion around what's best for you. And then similarly, when it comes to family planning, you might be interested in pregnancy prevention or in having a child. And if you have the ability to bear children, then there are, again, specific interactions to be discussed and planning during those stages, whether it's pregnancy prevention, infertility treatments, or pregnancy. And so these are really dynamic conversations that can be complex. We don't have all the answers, but we certainly know it needs to be discussed. And so including your sexual and gender preferences and health in the conversation about your epilepsy really can improve your seizure and epilepsy care. So the last slide is just some references. So if you're logging onto this and you want to look where I got some of these figures from, they can be referred to. And with that, I'd like to open it up to the group and the panel for the continued programming we have.
So thank you for that wonderful presentation. So now we all have a better understanding on the health considerations for the LGBTQIA population and definitions and all of that, and what matters for the epilepsy community and care if you identify as part of this population. So thank you for that wonderful presentation. And I'm excited to start our discussion. So as I said at the start, if you have any questions, please put those in the Q&A box, and we'll definitely get to those if we can with our panelists. But I want to start out with Dr. Johnson. The presentation, as I said, did a wonderful job defining LGBTQIA plus sex and gender for us. Can you also define the term gender affirming healthcare and its importance in this discussion? I know it was brought up during the presentation.
Thank you so much for that question. Again, thank you for including me. I'm really, really honored to be here today. So gender affirming care is healthcare that takes into account kind of all aspects of a person's identity. And gender affirming in particular, we should be providing supportive and validating care. Of course, this is kind of basic things like using the appropriate name or pronouns or body part terminology for people. But even more so, I see it as really connecting with a person as an individual and figuring out what are their values. I think about a time when several years ago, I had a patient who was a transgender woman with epilepsy, and we were talking about different treatment options. And we tried several medications, and I said, okay, I'm going to suggest another medication that I think could work. There's a potential it could interact with your hormones, but we'll keep an eye on that. And she said, nope, absolutely not. My hormones and my gender identity is the most important thing. And I said, of course, why am I? It was a real eye-opening moment that I had not been taking that value into account. So I think gender affirming care is really working with a person to figure out what are their priorities and how can we provide the best care.
Yeah. Thank you for sharing that experience. I know with my chart, we're able to, include our gender identity, and I'm able to include, that I am bisexual on my chart. So doctors are able to, have that information going into the chart. So thank you for sharing that. And Derek and I will go back and forth asking questions. So Derek, over to you to ask the next question.
You discussed the healthcare disparities seen in the LGBTQIA plus population. What are some ways individuals in the healthcare community can work to improve these disparities?
Thank you. Yeah, this is a big question and a big topic. And I certainly don't have all the answers here today, but hopefully, as a healthcare community, we're really striving to provide inclusive care. And I think awareness and education and knowledge is obviously where the starting point comes from. And so, from an individual level, I think it's about educating yourself and making sure that you're learning about your conscious and unconscious biases and how that can affect the individual patient. And I think being respectful and inclusive is really important when you approach someone in your office and when you're taking care of someone. And so, things that have been brought up already that are really important, right? Um, Acknowledging and recognizing pronouns and using them in the appropriate and accurate way. I think being sensitive to the histories and the topics and knowing that some people might be less comfortable talking about it and more comfortable, but trying to provide an open and safe environment. And maybe that means on the first is that you don't go through all the details, but start to open that dialogue and conversation. I think letting from a provider standpoint, letting your patients know that we have some information. There's a lot of information. These will come in the next questions of, things we still need to learn and really know and understand to provide even better care. But knowing that you have some knowledge about this and are going to approach their care in that way, I think is really important. And then being an advocate and saying, how can I bring this knowledge and these practices to my practice as a whole, maybe to the larger institution, to my community, right? And so that, change can be really impactful on the individual level in that office, that moment of time, but can you even do something that can make a bigger impact? And so, standing up and providing advocacy and being a voice for this community, I think is important.
Thank you so much for the answer. Thank you.
Yeah, and I think having you all here is, providing a voice and advocacy. So thank you all. I see Derek nodding along.
Definitely, great.
Dr. LaRoche, we want to come to you next. The presentation shared that LGBTQIA plus people reported higher negative experiences with their healthcare providers. We saw that in that chart. Can you discuss what an inherent bias is and how that may impact someone's care that they receive?
Oh yeah, definitely. And thank you for that question. And again, thank you all for including me in the panel, and to Dr. Waldman for an excellent overview. Yeah, I think this concept of inherent bias or implicit bias is another term for it, is really important in general, but specifically when we're talking about the relationship between patients and physicians. Sometimes it's referred to as unconscious bias or subconscious bias. You might be more familiar with that. Basically, I just think of it as these are ways that we discriminate or stereotype each other despite our very best intentions, to be aware and sensitive to these issues. So, I want to just share a quick story of when I learned about my own implicit biases, and this was some years ago through this story. You might have heard it, but I think it's worth repeating. A father and his son were in a terrible motor vehicle accident. Unfortunately, the father was killed at the scene. The son was very seriously injured, was rushed to the emergency room, and needed a surgery for his care. So the trauma surgeon came into the emergency room and looked at the boy and said, "I can't operate on this patient because he's my son." Now, if any of you heard that story and just even for a second went, wait a minute, how could that be? And when I heard the story the very first time, I had that thought for a couple of seconds. I will tell you that I heard that story at a healthcare and gender and equity conference. And the point there was, oh, like that couldn't be the son's mom, right? So that was the point of the story, is not to think about, a trauma surgeon being a female, but let's take that one step further for this population. Well, then the son could have had two dads, right? And so if it took you even a few more seconds to think, well, of course that that's his mom, or that could be his other dad. I think that's a good example of our own implicit biases.
Thank you for sharing that story. That's definitely a really good example, and I think got the group thinking about that. So thank you. Back to you, Derek.
Hi again. Um, Dr. LaRouche, so as a follow-up, since we're continuing to learn and improve, do you have any tips for both the patients and the providers on how to make sure that they're checking their bias, their inherent bias ahead of the appointments?
Yeah, and I think this is so difficult, and I'm sure that Dr. Waldman and Dr. Johnson can attest to this. On the physician side, I know every time I walk into the room, I have the very best intentions of being completely objective, right? So make no assumptions about the patient that I'm walking into and meeting for the first time and that's under my care, and particularly when we're taking a sexual history. So first off, as an epileptologist, a patient might be like, "Why are you taking my sexual history? I'm here for my seizures." So to be upfront about why that's so important, we've heard about how important the interaction with hormones is, but just to be objective when I start asking questions as far as are you sexually active? Who are you sexually active with? And making no assumptions about that. I'll share a story, similar to Dr. Johnson. Not too long ago, I was in an exam room, and I was hurried that day, end of the day, and I was just going through questions with a young woman, and I said, birth control, and she said no, and I said, we need to talk about birth control, and I saw her eyes go down a little bit toward the floor, and she said, I don't date men, and as a lesbian physician myself, I was just horrified at my own reaction to that. So I think these are things that we all have to be aware of and think about. It happens on the patient side too. And I thought, think about myself as a patient. I walk into the room and I'm seeing a new physician for the first time, and in walks a white young male in scrubs or something, right? And I'm sitting there thinking, automatically assuming this guy's not going to be somebody I can trust, not somebody I can talk to. Well, what if that white male happens to be trans and have epilepsy? right? If you knew that, you don't know that on the outside because that's kind of invisible. But if you knew that, you maybe, automatically feel more comfortable.
I think once we figure out that we did make that jump, that we say, okay, you know what? I'm sorry, I apologize. And go forward, they have a more of a, oh, okay, they knew they messed up or they made a mistake and they trying to do better. That's amazing.
Thank you for that.
Yeah, and just echoing that, thank you for sharing that, personal experience and all of that. And I did want to open this question too to Dr. Waldman and Johnson in case they had any tips they wanted to share around that, the same question. And if not, that's fine, and we can continue the discussion further.
I think it's a learning process for each of us, especially, I went to medical school, gosh, maybe 15, 20 years ago. But at that time, there was not such awareness, and it was drilled into us that, the way to, be the best physician is to always take the sexual history and think about pregnancy. And, now, as Dr. LaRoche said, it's not relevant for everyone. And so I've been updating my, my note templates to just say, okay, how can I not make assumptions in my note template? Should I, do I need the birth control template in there, or should I instead put the, what is
I think if I can, share a story too. Obviously, some of the stories that have been shared is kind of how, a healthcare provider might approach the appointment and kind of biases and practices. But an experience I had, which I think is maybe to share for, people with epilepsy on this phone call, it's very common for people that take contraception to prevent pregnancy, that whether it is a pill, a ring, there's all sorts of types, to kind of not put it on their medication list. A lot of people, sometimes don't think that's medication. And again, since that is something that's used medically and sometimes not for pregnancy prevention, but there's some other indications, as providers, we're kind of known to kind of ask for it. But I had someone who is on hormone medications for their transgender care, and they didn't share it. And I happened to be looking at the pharmacy page, so it showed it because it was a prescription. And so I asked them if I could talk about it, and they said, "Oh, I don't consider that a medication. It's, this is who I am," right? They don't look at it as a medication. And I think, that that is a totally acceptable opinion. And it's kind of great that someone could feel that way. But then it can be important when we're trying to pick the medications, like Dr. Johnson said. In particular, estrogen can be one that can a seizure medication can interact with it, right? And some of our seizure medications decrease the efficacy of the hormone medications. And so while an individual might not look at their hormone medications as medications, right? It's making them who they are, so their features match their gender. That's something, for an individual to, find a provider that they feel safe and comfortable talking to them about, so that it can be an important discussion, so that we make the right decisions when we're approaching your epilepsy care.
Yeah, no, thank you for that story. As a woman with epilepsy who's on birth control, you definitely had me thinking, yeah, I never marked it as medication. And then when I stopped it, my seizures completely changed, and we found, a catamenial component or hormonal component to my epilepsy. So yeah, you definitely had me thinking there, where I was like, yeah, I never listed that as a medication and I was taking. So thank you for sharing those stories with us. And you had a nice transition into our next question for Dr. Johnson around transgender patients with epilepsy. So Dr. Johnson, transgender patients with epilepsy may choose to undergo gender-affirming hormonal therapy. And we've talked about this a little bit, but how might that interact with their anti-seizure medications and seizure control?
Yeah, great question. So there's a couple things we need to think about there, and we do see bidirectional effects between some hormones and some seizure medications. And so I think of it as lamotrigine, special circumstance. This one gets induced by estrogen. That is, we have to adjust the dose, and we have to think about an estrogen lamotrigine concentration difference. And most of this we know from cisgender women or from people who are taking hormones, not necessarily for gender affirming care, but we do think it is the same when used for gender affirming care, that the lamotrigine level is significantly lower in the presence of estrogen. So we need to be aware of that. Going the other way, a number of our medications, probably about half of our medications, are what we call enzyme inducers. And that means that they speed up the metabolism of some other medications, including estrogens, including hormones. So that's the other thing we need to take into account. And we're lucky now in the electronic medical record that if a hormone is on the medication list, it will give us an interaction. But even so, I always like to talk, if it's relevant, I always like to talk about it with the person with epilepsy in front of me to say, hey, yep, I see you're taking estrogen. We're going to make sure that we're on a medication that's not going to interact with that as part of that gender affirming care. And then how can this affect seizures? So one big way, as you alluded to, if someone starts or stops estrogen, that can not only affect the levels of some anti-seizure medications, but it can theoretically affect seizure control. So from cisgender women who take estrogen for either birth control purposes or for hormone replacement therapy when going through menopause, there is a theoretical potential effect of estrogen to increase seizures. Now, this is not to say that we don't use estrogen or that we should not, but it is something that we think about, and it would be definitely a reason to let your epileptologist or your neurologist know if you're starting or stopping estrogen. We know less about the effects of testosterone, but testosterone is metabolized to compounds that have both pro-convulsant or anti-convulsant. So I would say always let your neurologist, let your epileptologist know if you're starting or stopping hormonal therapy so we can work through it together.
Thank you for that answer and that tip of always talking with your provider and, having that open line of communication. So Derek, over to you.
Let's see. But Dr. Walden, what can LGBTQI plus patients with epilepsy do to make sure they are receiving the best care?
I think that's a great question and kind of points we've been making, hopefully throughout this webinar, that you should find a neurology care team that you can feel open and safe with talking about your gender and sexual preferences with, and things like gender affirming care and pregnancy plans or pregnancy prevention plans. And I think that can maybe be difficult, right? We look online and see a picture, and how do we know? There are a few links that hopefully are going to be included here that are also on the Epilepsy Foundation's website that can be a nice starting off point of a provider directory that has some providers and practices that self-identify as being safe and open for the LGBTQIA population. UCSF in particular has a really robust and great webpage specifically around transgender care and transgender issues. So maybe you even have health conditions outside of epilepsy. And so, while the internet can have a variety of information that isn't always trustworthy and accurate, knowing the websites you're going through are important. And so in that way, using links from the Epilepsy Foundation can be, a good starting off point. And then I think it can be difficult, though, depending on where you live and where you're getting your care. The introduction of Dr. LaRoche was helping expand rural access of epilepsy care, because when you get into some of these issues, they are complex and they are detailed, and someone who's an epilepsy specialist really might be needed. Although there are many great and wonderful general neurologists out there that are hopefully well educated about these issues and approaches as well. And so, maybe it is about accessing some telemedicine resources that might not be as close to you to get some different aspects of care. I mean, I think it's very difficult that there are certainly some regions where this is not an area where it might be safe and open for you to kind of be in an environment like that. But hopefully you can find a provider locally that you can seek out, maybe using some of these directories and websites that can be a starting off point. Because I know I've said it now a few times, but I think it's an important part of your healthcare. It's who you are. It's what you are as an individual. And you have epilepsy usually for your whole life. And so there are different stages of life and parts of life. And, I think your gender and sexuality are part of that.
Thank you. And I see our colleagues have been putting
Good
those
answer.
links in the chat for us. So everyone should have access to those links that you mentioned.
That's what made it. Thank you for that. Thank you.
Yeah. And we come back to Dr. Roche. We talked about stigma in the presentation. And so stigma is a common comorbidity seen just within the epilepsy community, but also within the LGBTQIA population with epilepsy. What are some ways individuals and the community can help combat this stigma?
Yeah, well, I think things like what we're doing today with this webinar is just so important. I think, really education is one of the key components of combating stigma. And, we need these particularly not just for, patients with epilepsy, but probably more importantly for healthcare providers. Not just epileptologists, but as patients know, often the first interaction they have with the healthcare provider is in the emergency room. Right? Our emergency room providers often don't really, I think, get any training on the stigma of epilepsy. So we need more of education to healthcare providers. And as I know, Dr. Waldman and Dr. Johnson have been involved in. We just last December had our annual American Epilepsy Society meeting. Thousands of epileptologists attend that meeting. And we had a keynote session that Dr. Johnson gave, a very, very good session on gender equity in epilepsy. So, I think that's the start. From an education standpoint, one of my favorite things, I think, as a physician that I do in the exam room is education, just educating patients about their seizures. As we talked about, I practice in a rather rural community. So I'm seeing patients that we're discussing for the first time the fact that they have epilepsy. This is a new diagnosis for them. When you say that word, I mean, there's so many times I wish we could just change the word because the word has the stigma, right? And so, a lot of times I find myself starting out by saying, you're having seizures, and that seems to be a little more comfortable because obviously when somebody comes to see you because of having seizures, but to say epileptic, and that term, kind of the connotation that you are epileptic and not that, well, this is a medical condition I have. By saying epileptic, it kind of makes it like that's kind of who you are. So I know those are some of the things I feel like we need to, get away from. Another story is from a patient, some years ago, but just kind of brings home this whole stigma, and it impacted me. A patient that never had tonic-clonic seizure or grand mal seizure, didn't have the obvious seizures. The only types of seizures she had were the complex partial, what we now call focal seizure, where just zone out, for like a minute. And, I'll never forget, she shared with me, she said, I tell everyone I'm diabetic. And that if I zone out for a little bit, I'm just having, my sugar's low and I'll just take a sugar tablet because it wasn't embarrassing to her to be diabetic. But the stigma surrounding epilepsy was so strong. So, I think, we all just need to continue combating that stigma. And then I think this has been referred to before by others as the importance of visibility. And I completely understand that a lot of times, we're not in a safe place where we can be out about our sexuality or out about our epilepsy. But for those of us who are fortunate to be in a situation or a cultural or a town that's big enough to feel safe, I think it's really important that we can be visible in those ways.
No, I think those are all great. And as I've been on my almost 20-year journey with epilepsy now, I have complex partial seizures. And yeah, oftentimes didn't want to talk about it or anything like that. But yeah, have been more open, as you were saying, with epilepsy, sexuality, things like that. And everyone's journey is unique. So I think the more we talk about it and do, as you were saying, educational opportunities for both patients and providers, we'll be able to help combat that stigma. And I did get to see Dr. Johnson's presentation at AES, which I will agree, it was very wonderful. So I'm glad you shouted that out.
You guys are too kind. Thank you.
And I see our colleague Tom is putting more links in the chat too. So thank you, Tom. And then Derek, I think it's over to you now.
Question is for Dr. Johnson. What are some areas for future research in this area of epilepsy?
Great. Thanks for that question. I think this is a field that we are just kind of starting to think about and talk about. Epilepsy research as a whole, we are identifying disparities all over. I think we all kind of know that our healthcare system has historically not done a great job of providing equitable care to people. So we are kind of now uncovering that, yep, in addition to these other disparities that we know about, there are disparities in sexual and gender minority people with epilepsy as well. And we absolutely need research to say, why is that? There's some suggestions that it's possible that the burden of epilepsy or the prevalence of epilepsy might actually be increased in sexual and gender minority people. I think that goes back to some of the things that Dr. Waldeman wonderfully covered in the presentation earlier about social determinants of health, chronic stress, and the accumulation of chronic discrimination and bias. These affect us in so many ways. Chronic stress hormone elevation can actually lead to physiologic changes in the body and changes even in the encoding of DNA as well. So there's a lot of potential ways that this, years and years of stress can have accumulated effects. So I think that's one area of research to say, okay, what is the epilepsy experience in the sexual and gender minority community as a whole? And then I think another big area where we need research is to say, okay, are there any significant effects on seizures of gender affirming care? And if so, what are the best ways to address those? Because so far, everything we know is really extrapolated from cisgender people using hormones. We need some prospective studies that say, okay, hey, this person with epilepsy is going to get their gender affirming care. Will that affect their seizures? And if so, how can we best manage them? So thank you. I think that's a great question. There's probably many more areas, but those are two that I see in need of a lot of research.
Thank you so much.
And as we're coming up here, that hour always goes so quickly on these webinars. I wanted to just open it up to everyone, all of our providers here, for any final thoughts you'd like to share with our listeners on this topic. I know we've covered a lot, we've shared a lot of links and information and everything, but maybe we can start with Dr. Waldman and popcorn to everyone for any final thoughts on the topic.
Yeah, I just want to, thank the Epilepsy Foundation again for having this, right? I think this supports the mission of, trying to increase awareness and knowledge and just a conversation about this. There's a lot of options to treat epilepsy, although it's, a chronic disease. And so I think it's about finding a healthcare team and provider that is a team, right? That works with you and that supports you. And so I'm really lucky to be in a place where I feel like we're providing that care to our patients. And so if you're listening to this because you're struggling with your epilepsy or you're having issues with your care, hopefully some of the links provided and some of the information here can help guide you to kind of change your care and seek out providers who have an open ear and are safe and can listen to you and get to know you and everything that's important about you, as well as treating your epilepsy.
Thank you for that. I see Dr. Johnson's off mute first, so we'll go to her.
No, just I want to echo that thank you to Allison and Derek and the whole Epilepsy Foundation for putting this on and for really initiating this conversation. It's so valuable. Go to Dr. LaRoche.
Yeah, I guess I want to thank all the participants for being here, and hopefully you'll learn some things that you can share with friends and other folks and patients that and I just shared a couple stories with you today, but I just encourage you to speak up in the office when you're talking to your physician, and not just your epileptologist, but any of your physicians, because I can attest, and I'm sure Dr. Waldman, Dr. Johnson agree with me. I never learned more or more important things than what I learned from my own patients and that experience in the office, and it's absolutely made me a better physician. So I just want to thank you and thank my patients for what they teach me.
Well, thank you for sharing that. We're getting a lot of thank yous from folks, and someone sharing that they're 22 years seizure free, which is exciting. So congrats to Michael. Thank you for sharing that. Seeing some applause from our panel. And then also, around sharing your story, my colleague Alyssa just put a link in the chat. If you're ever interested in sharing your story, we have our e-journey blogs where you can share your journey with epilepsy. So you can always do that. But I'm going to pull up some closing slides here real quick to close us out and talk about a few more resources that we have available. But, first, again, just thank you so much for joining this discussion. And, thank you for your support of the Foundation's mission by joining the webinar today. And a special thank you to, Drs. Waldman, LaRoche, and Johnson for joining us and sharing their expertise with us. And a very special thank you to Derek for co-moderating with me today. It's the first time co-moderating with someone, so it was very fun and, especially fun for Pride Month. So thank you, Derek. This webinar, as we shared, has been recorded, and we'll be posting it soon on our Foundation's YouTube channel, where you can find videos on many other topics as well. Last year, we did one on transgender health and epilepsy, which is up there. So I want to share about our support groups. We offer a variety of support groups for members in our community to connect and get support from one another. We also offer bereavement support groups for those in our community who have lost a loved one due to epilepsy. So the calendars here show the ones offered in June. So to learn more, you can visit epilepsy.com/support groups. And then the bereavement support groups are offered once a month. And you can see the information there on the slide. We also have our legal defense line. As we've discussed, people with epilepsy shouldn't have to face discrimination and should be able to be open about their epilepsy and their sexuality. And the Epilepsy Foundation's Jean A. Carpenter Epilepsy Legal Defense Fund fights epilepsy discrimination across all aspects of your life. You can just see some of the examples there on the slide. So if you ever need help, you can contact them at legalrights@efa.org. And lastly, I know this has been shared in the chat a few times, but we have our helpline. I should say last but not least, we have our helpline. So as always, you can reach out to the Foundation 24 hours a day, 7 days a week through our helpline. The numbers are on the slide and are available in English and Spanish, or you can email us at contactus@epilepsy.com. And our resource specialists, who are wonderful, are there to answer your questions and get you the answers that you need. And thank you for joining us this afternoon for our second annual Pride webinar, and a happy Pride Month to you all. And again, thank you to all of our panelists for being here, Derek for co-moderating, and all of the participants that joined us today. And I hope you have a wonderful rest of your day.